Hi, good morning. Thanks for coming. I know some of you, especially the first years, don't know who I am because they only let me come here every once in a while. So I'm Tad Nowinski. I'm on the plastic service. And this morning we're going to follow a few topics from your basic science books. It's one of those assigned things to get you, sort of ready for the OCAPs. So a lot of the stuff here, most of it's in your book. It's more to show you examples and emphasize some things. There's going to be three parts this morning. The first part is going to talk about a little bit about congenital and acquired eyelid disorders. Not so much ptosis or entropy or things like that too much unless it's congenital. The second part you're going to get bombarded with tomorrow and Saturday, but I'm going to throw my 2 cents in on a little bit on anatomy and what you'll see in the cadaver lab Saturday. And to finish up, we're going to spend most of our time on eyelid tumors. If anyone has to leave, certainly not offended. Feel free to go whenever you need to. So let's talk a little bit about congenital and acquired eyelid disorders. As you know, they're rare. We hardly see them here at all. They're usually isolated with no other facial or systemic problems. And like most congenital disorders, it happens in the second month of gestation, either due to failure of fusion or arrested development. So by far, the most common eyelid problem that's congenital, that's the syndrome that we see, is blepharophimosis. So I'm going to talk a little bit about that. What is blepharophimosis? What do you need to have it? Well, you have to have telecanthus, which we'll talk about in a second, epicanthus inversus, which we'll also talk about, but basically that means an epicanthal fold that's more prominent in the lower eyelid. It's almost pathognomonic of blepharophimosis syndrome. And severe ptosis, usually poor levator function, but not always. And phimosis just means shortening, so you're tight and short horizontally and vertically. So what's the difference between telecanthus and hypertelorism? Board question. Telecanthus is what this girl has with blepharophimosis. Look at her pupil reflex. The pupils are pretty much in normal position. It's the medial canthal tendon and the epicanthal fold that make it look abnormal. So you have normal interpupillary distance with the long medial canthal tendon. Hypertelorism is a more severe, you could see it sometimes with blepharophimosis, you see it with other craniofacial disorders, where there actually is a wider space between the orbits. Autosomal dominant blepharophimosis families will come in and you'll see a few people. It's not uncommon to see mom and a child come in at the same time, and you can look at them and know the diagnosis across the room. Unfortunately, to fix things that are important, it takes multiple stages with blepharophimosis. It may include medial canthal flaps, tightening of the tendon, moving things around, and also ptosis repair. So when ptosis is horrible during early childhood, we have to improve it pretty quickly. So temporary procedures like sutures or different types of synthetic devices can be used to prevent amblyopia. The other type of ptosis we see in blepharophimosis is kids who have normal vision, but they may come in with the head chin-up position, holding their brows up, just trying to get the lids open at all. So let me just show you an example. What can we do for these children? This is a girl with long medial canthal tendons and epicanthus inversus and ptosis. And there's a number of different techniques in the medial canthus we could use to rearrange tissue. Most of them are based in somewhat on Z-plasties. So in her case, we made a little double Z-plasty with you can see a Y here in the middle. It's going to be a Y to V advancement also. And after we make the flaps, we're actually going to shorten the medial canthal tendon. So you can see this forovicral suture going to the medial canthal tendon to shorten it. And here's what the patient looked like soon after. And the slide on the right shows after ptosis repair. This is a patient that came in, I think, my first year of practice in Lansdale. All the classic findings, and here's what he looked like a few years later, having the medial canthon and the ptosis surgery. Nothing is perfect when we do these cases, but I think there's a lot of good improvement that could be made. Let's talk about some other congenital eyelid deformities. Some are rather common. Most of them are pretty uncommon. We're going to talk about this picture, at least I think it still is in your book. It shows some of the 4 types. The ankyloblepharon right here, epiblepharon, epicanthus, and uriblepharon. Let's talk a little bit about each of those and show some examples. Ankyloblepharon we hardly ever see there. It's usually a newborn, the first few months of life. It's a web of skin. It's a web of skin that goes from the upper lid to the lower lid. And luckily, usually, that's all it is. It usually is not a deformed lid. All the other layers of the tarsus and the lid are fine. And usually a simple repair with the hemostat, cutting and just freshening up the edges is all that a child needs. Epiblephron is very common, as you know, in certain families and certain geographic locations. It's more common. It's a horizontal fold of skin and muscle, usually medially. And you can see that this will push in the lashes of the lid. It's not true entropion, because if you pull the skin away, the lashes are not really rubbing at the eye so much. And the nice part is that with improvement of facial growth, especially the maxilla becoming more prominent, this often will go away. It's very uncommon that you have to operate on these children, or that they get a lot of keratitis. Usually you have them use ointment at bedtime or lubricants during the day, and they do fine for a few years, and then they don't have to worry about it. When we have to do something, we will excise a little bit of skin and muscle, and we'll fixate it to the deeper tissue of the retractors to improve it. Epicanthal folds were classified probably over 100 years ago by Johnson, and he came up with 4 major classifications. And they're shown in the drawing again from your book. First is superciliaris, where the brow area is involved. The next is palpebralis, where the upper and lower are about equal. The third is by far the most common, tarsalis, which is a normal finding, and that is mainly in the upper eyelid crease. And the least common is the epicanthus inversus, which we talked about, blepharophimosis. So most of them will improve. All 3 out of those 4 will improve with facial growth, like the epiblephron, except for epicanthus inversus. Epicanthus inversus doesn't usually get better. As I said, epicanthus tarsalis is extremely common and normal. Epicanthus inversus, think blepharophimosis. Okay, uriblephron is an interesting thing. You have a widening horizontally, and you have a vertical shortage. So the lid is longer, but it's also being pulled downward. There's a skin shortage in many of these children. And look at the lateral canthal tendon. It looks slightly lower than the medial canthal tendon. That's not the normal. You'll be hearing tomorrow, the lateral canthal tendon is usually like 2 to 3 millimeters higher than the medial canthal tendon. So when it slants down like this, that is a sign that it could be uriblephron or a different abnormal problem. Unfortunately, your Academy book still uses this term, which is probably not politically correct, but it is still there, so I'm putting it in. And we have to worry about skin shortage. So some of these kids would just need to have their canthus reformed, and some of them may need skin grafts. This is a child I saw when I was a fellow, where you can actually see those inferior corneas on both sides are hazy because of exposure. Many of these kids have Down syndrome. They can be associated also with blepharophimosis, and they could also happen on its own. So in this child, as you can see, mainly the canthus was operated on, and the corneas cleared up nicely. And later on in life, the child, when it was a little bit older, had a little bit more surgery done. Okay, congenital ectropion by itself is very, very uncommon. When we see it, it often can be due to blepharophimosis again, or Down syndrome with the uriblephron. And sometimes you can see it with an unusual autoimmune problem, which I've seen a couple cases of congenital ichthyosis. And these are very difficult to treat. You try to do as little as possible because you know how abnormally they heal up with almost any type of skin surgery. This is a patient that was seen at Jefferson Neonatal Unit, and it's still in your Academy book. It's an uncommon problem called congenital eyelid eversion. It could be 1 eye or 2 eyes. Sometimes it can be associated with inclusion conjunctivitis. Sometimes it can be associated with Down syndrome, but most commonly it's sort of nonspecific. And you try to push these lids down. You try to have the nurses patch the lids when they're sleeping to push the lids down, and that may help lubricating everything. When that doesn't work, sometimes we will put in some full-thickness sutures, go to the operating room with the mask. It's almost like fixing entropion with sutures. We're not cutting anything. We're just putting sutures in. And this child, unfortunately, didn't get better on their own. And this is what they look like after having the sutures, and ended up not ever having a problem afterwards. So that's something that's unusual. This is also something that's very unusual, eyelid colobomas. I don't know if you'll ever see one. But it actually involves a missing part of the lid, many times full-thickness eyelid. It's an embryological cleft, and usually when it happens in the upper lid, it's an isolated finding, and that's the more common one. When it happens in the lower lid, it can be associated with other facial deformities. And, they see more of these over like a children's hospital with the different facial dystonias. Here's a child that I took care of that, as you can see, has a chunk of the lid missing. This patient was born with this missing defect here. If you flip the lid, you can see there is pretty good tissue here, but there's no normal tarsus or tissue here. We're always worried about amblyopia in these children. We really don't want to share and sew the lid shut for a few weeks to share tissue. So we want to try to do the techniques we do for basal cell and other things. And usually in this case, if you go over laterally far enough and you loosen up all this tissue, you're able to bring things together pretty well. And this child did well, needed a little bit of touch-up later on in life, but actually did very well. Capillary hemangiomas, I don't take too much, I don't see too many myself. These are not present at birth, but show up within a few weeks or a month. As you know, they increase in size up to about age year 1 and then go away. They can be very difficult to treat. You're worried about amblyopia with these cases, of course. You don't want to do anything major if you don't have to. When I was training, and still a lot of times now, the most common treatment was injection of steroids right into the hemangioma under anesthesia. Systemic steroids are used, but either one of these can cause adrenal suppression, and it has to be very closely watched with the pediatricians. Lasers have been used, especially CO2 lasers. Some dilators have been used with moderate. Sometimes if there's a cavernous portion or there's a palpable area that's very big, surgery can sometimes be done. And a few years ago, propranolol is the more recent advancement in that, and you're probably all familiar with the New England Journal articles. I'll just show in a second. These are 2 cases actually from before I was in the business. These are 2 patients of Dr. Flanagan's that he lent me the chart. These are capillary and mixed capillary cavernous hemangioma cases. And how were they treated? They weren't. This is a spontaneous improvement over time. There was no amblyopia, and it was decided to let these alone, and this is what the children look like with a little bit more time. So they will spontaneously improve. How much is up in question, but often very much. And the New England Journal in 2008 was the first one to talk about the use of beta blockers for the use of capillary hemangioma. Okay, I'm not going to spend a lot of time on eyelid edema. It can be caused by so many different things. You guys deal with it in the emergency room and in clinics all the time. To me, the most important ones that you don't want to miss are people with Graves' ophthalmopathy who have a lot of edema, distinguishing them from people who are infected, have cellulitis, distinguish them from people who may have pseudotumor. Not a real severe case, but you can certainly see the edema on the lid. And that's all I'm going to talk about, edema. Floppy lid, I'm going to talk a little bit more because there's still, I think most ophthalmologists in practice don't realize how important floppy lid syndrome is for the rest of the body and the rest of the eye. So I'm just going to talk a little bit more about that. This was described in the 80s, so it wasn't even called anything before that. This patient was referred for ptosis evaluation. And you can see by just looking at the patient that their lashes are pointed downward. Something's wrong. A patient also had chronic mucus discharge and had very loose and rubbery eyelids. So why is it called floppy lid? Because it's very easy to evert it. Some of these patients come in saying, I wake up in the morning and my lid is inside out. My lid is everted. That's the worst case. And they usually get a chronic papillary conjunctivitis on their upper lid. So here's what the patient looked like, and you flip his lid, and you can see that he has just a beefy red papillary reaction, and you could evert his lid very easily and pull it away from the lid. It's not touching the globe very much at all. These are 4 examples from the literature that I got that just show some different varieties of floppy eyelid. It's thought that eyelash ptosis, which is the name they gave downturning lids, may be sort of pathognomonic for this. So if you see downturned lids on a ptosis patient, the lashes are going down, think that this isn't maybe a simple ptosis. Just try to make sure you flip the lid and see if they have floppy eyelid syndrome. Floppy lid syndrome is one of the unusual syndromes where the upper lid becomes loose. Usually the lower lid is very loose. We know from ectropia and entropia and all the different things. But the upper lid usually doesn't get loose like that. And in this case, it's actually because you've lost the elastin fibers in the tarsus. There's actually a pathologic thing that could be seen. It's not just a stretching of tendons. And it's usually thought to be due because of upregulation of these enzymes. It's thought that it may be stimulated by people sleeping on that side, rubbing their eyes a lot. And if you ask people if they have it on one side, what side do you sleep on, they often tell you the side that is abnormal. Now, why is it important other than fixing their lid? Well, more than 90% of people with floppy eyelid syndrome have obstructive sleep apnea. So you really want to ask them. Many people have the sort of classic sleep apnea body shape, but not all of them do. You want to ask them if they snore. Ask them if they have problems breathing. Ask them if their primary has talked to them about sleep studies. The opposite, only about 5 to 15% of people with sleep apnea have floppy lids. So it's not a high percentage, but from our standpoint, we have to think of it a lot. And as you know, the treatment options, usually the most common ones are the CPAP units and some mandibular devices. The CPAP units are very common. And why is that important? Well, sometimes it helps us. We want to treat these very symptomatically in the beginning until we know for sure what we want to do. And I have seen a couple patients improve tremendously once they start a CPAP unit, and no one knows exactly why. But it does happen. It's in the literature. So we like to wait on these if we can. And because the surgical therapy is not the most perfect treatment in the world. What we do is basically we treat it like a basal cell or a cancer. We take out a big chunk of the lid. And it's hard to know how much you're taking off what you're thinking. A normal person will be almost a third to a half of their lid, and you sew it together. And sometimes a year later you have to do some more. So recurrence is common, and it's hard to know how much is enough. Now, why is it important to talk to the primary doctor? Well, patient has a floppy lid, and if they do have sleep apnea, it's not treated, there is an increased risk of cardiovascular disease, stroke, metabolic syndrome, basically increased morbidity and mortality with this syndrome if it's not treated, obstructive sleep apnea. But most ophthalmologists don't know about the ocular conditions that are increased in the literature with sleep apnea. And those can range from just CPAC-associated dryness of the eye. There's an increased incidence of non-arteritic ischemic optic neuropathy. There's an increased incidence of papilledema. And there's an increased incidence of normal tension glaucoma. And all these mechanisms are very poorly understood, but they're well documented in the literature. So when you see floppy lid, think systemic, think the other parts of the eye also. Okay, that's all I have to say about floppy lid. You all have more experience than all primary doctors and most other physicians already, even the first years after a month or two, of treating hordeolums and chalazions. So I'm just going to briefly go through, if you haven't done your first chalazion procedure, and most of the time we're talking about the meibomian glands of the tarsus, but sometimes we're talking about the glands of Zeiss with the eyelash. If it's infected, sometimes they're called a stye. It's a very sort of hazy distinction between a stye, a hordeolum, and a chalazion, even in the literature, even in your basic science book. You guys know all the treatments for this. Just a couple things. I almost always remove tarsus when I do a chalazion. Some parts of the country just make a slit in the tarsus and curette it out. I almost always remove it. And I like the so-called cruciate technique. Sometimes I'll make one and then just cut around it, and sometimes I'll make a cruciate. But I'll always remove tarsus and conj. The thing I notice about the first few times that you're doing them is that you're afraid to go into the tarsus. You'll remove conjunctiva in those areas, and you'll think that you remove tissue. Sometimes we have to make sure that we're being a little more aggressive, and that's what we're there for. You're going to get experience with us, and we're happy to do them. Thank God there's a lot of chalazions around for us to share with you. Okay, now we're going to switch gears to the second part, which is anatomy. Tomorrow and Saturday, you're going to get a lot of anatomy talks. Tomorrow night, unfortunately for you, for those that will be there, I'm giving 2 talks on anatomy on the lower eyelid and the lacrimal anatomy. So since they didn't give me upper lid tomorrow, I'm going to throw a little upper lid in you because it never hurts to hear too much. So I'm going to just go a few minutes on upper lid anatomy. This is more like what you'll see. This is from a book that was made years ago for dissection, and it's very nice. And Ned Bedrosian has also a lot of nice material. He does a great job. This shows the clinical correlation. We've cut through the skin and orbicularis muscle, and this is the orbital septum. So a thickening of the periosteum, called the periorbita, arcus marginalis, is where the orbital septum originates. And underneath the orbital septum, the main difference in the upper and lower lids is what? laterally the lacrimal gland. So underneath it, we have a medial fat pad, and we have the large central, or we call it preoperative neurotic fat pad, because that's our main anatomic landmark for ptosis surgery. Laterally, no ophthalmologist, of course, would make this distinction, but lacrimal glands have been removed during blepharoplasties, thinking it's another fat pad. And then when it's not very enlarged or obvious and it's bleeding a lot, it sometimes can be confused with that, although the fat, of course, is yellow, and this is more like a pinkish-gray gland. But here you can see upper lid blepharoplasty, and here's a case where there was a very prominent orbital lobe of the lacrimal gland. I'm going to talk just a couple minutes on the most important part of the upper eyelid anatomy, the retractor, the levator muscle. So the levator muscle, you can see here in an old case where it was actually removed for a frontalis suspension procedure where there was no function of it. It's a very important muscle. This is what you'll see when you take off the second part the afternoon after lunch. You're going to be taking off the roof of the orbit, and you'll be looking down. So we're looking down into the orbit. This is the back of the orbit. This is the eyeball, and it's looking forward. So we're looking down. We've taken off the roof, and here is the levator. The levator starts back above the annulus of Zinn, comes forward for about 40 millimeters. It has some horizontal condensations here called Whitnall's ligament, and that helps suspend it. It goes forward, and it has a number of attachments. And clinically, when we're doing ptosis surgery, we sometimes can see this muscular area. We can see Whitnall's ligament, and we can see the changeover to the white aponeurosis tendon, if you will, of the levator muscle. Whitnall's ligament attaches somewhere near the trochlear superior oblique area over here, more distinct laterally, and it helps suspend the lacrimal gland. It doesn't divide it. It helps suspend it. Just to make confusing things, this is Whitnall's ligament. Where does the lateral canthal tendon attach down here in the orbit? This is called Whitnall's tubercle. So just to make it confused, Whitnall had a lot of good findings in anatomy, but it's confusing when you talk Whitnall's because you sometimes will confuse the two. But they're about 10 millimeters apart at least. So Whitnall's also helps to change the direction of the pull of the levator muscle. These are live ptosis external levator resection cases. You can see nicely preaponeurotic fat pad we talked about, Whitnall's ligament, muscular levator, pulling it down. It had been disinserted, tendinous levator, lower levator aponeurosis. Here, if it's been disinserted, again, we will cut through the orbital septum. So anatomy is important for certain things. It's nice to know that underneath the orbital septum is the fat pad, and the levator muscle and tendon are underneath. And that's our main landmark for external levator. For you, it's also your main landmark for trauma. Patient comes in the operating room and there's some fat sticking out of an eyelid laceration. What are you thinking? Well, the orbital septum's been entered, so you really have to either there or under local or in the operating room, depending on how extensive it is. You have to see if the levator has been damaged or if there's any other. So when you see orbital fat, you've known it's gone through skin, muscle, or orbital septum, and it's above the levator, so you have to worry about ptosis, traumatic ptosis. The levator, this is what you'll see tomorrow. It's all dried up and it's as good as it could be, but it's still hard to see. This is the preaponeurotic fat pad. So the orbital septum's been opened. This is the preaponeurotic fat pad. Underneath it is the levator. Levator has anterior attachments which go up to the skin, and they interdigitate with the orbicularis muscle up to about this area. So that forms the lid crease right here, and anything above it is loose. It hangs over. That's the lid fold. So that's the importance of the anterior function of the levator. Posteriorly, it attaches to the tarsus very tightly in the anterior border of tarsus, just a few millimeters above the lashes. This is just an example of how the orbital septum meets the levator. The levator has its attachments going to the skin, and then here it stops, and that's where the lid crease will be. And in certain eyelids where there is no lid crease or a low lid crease, it's because the fat actually goes over the tarsus. So this is above the tarsus. This is over the tarsus in certain Asian eyelids. The septum doesn't fuse to the levator until way down here, and that's why you get a big difference in the lid fold and the lid crease naturally. The levator, you'll see this. You're going to cut the levator. This is the levator. It's been back here. This is the back where it used to be. It's flipped over, and you can see the horns of the levator, the attachments. And the lateral horn is the most important one. It is firm, and it pushes into the lacrimal gland. It indents it. There is no two lacrimal glands. There's not an orbital and a palpebral lacrimal gland. It's one gland, just that the front of it is being pushed in, so we call it the different things, but it's really just one gland, and this levator pushes into it and theoretically makes it into the orbital and the palpebral lobe, but they're all the same gland. And underneath the levator's been disinserted here. You can see this peripheral arcade, which you don't see in the lower lid. You have the marginal arcade and the peripheral arcade. You'll hear more about that. It's between Mueller's muscle and the levator, and underneath it, so this is Mueller's muscle, which you'll hear more about. So since you're going to get enough anatomy tomorrow, that's all I'm going to say about anatomy today. So I'm going to have the rest of the lecture, I'm going to talk about eyelid lesions. First, I'm going to follow your book, and then I'm going to throw in, if we have time, some other things that I find helpful. Because you don't get a lot of experience, describing or just seeing lid lesions, or sometimes knowing how to call them and things. So let's talk about the most common eyelid lesions. Your book divides them into the three most common types: the epithelial hyperplasias, which are like 80% of what you're going to see; epithelial cysts, which are about maybe 15 to 18% of what you're going to see; and melanocytic or amelanotic nevi, which is going to be the third most common, but a very small percentage. So the most common epithelial hyperplasias are what many people would routinely call seborrheic keratosis or squamous papillomas. We'll talk a little bit about nomenclature in a second. Epithelial cysts, the most common ones we see are inclusion cysts. Those white things with a little pore in them, we'll show that. And nevi can often be, as on the lid margin especially, amelanotic. And they can be referred in by primaries or other physicians as, tumors, and that are worried about malignant potential. But luckily, most ophthalmologists, after you see a few, you'll be able to recognize more easily amelanotic nevi. So epithelial hyperplasias are the most common eyelid lesions. And since there's so many terms, there's like 20, 30 terms you can see in your book of what they're called by many dermatopathologists who want to be simple. Just say, we're going to call all these papillomas. It has nothing to do with the human papilloma virus usually, but we just call them papillomas because it includes a lot of the things that look like papillomas in other parts of the body. So squamous papilloma could be a skin tag, which they like to call acrocordon. It can be a frond-like elevation with multiple areas. It could be sessile or pedunculated, flat or on a tree stalk. And the other major papilloma is seborrheic keratosis. These look like someone took a different color or a very scaly area and put a piece of glue on it and put it on the lid. They're elevated often, they're crust-like, and they're very, very superficial, which is good for us to remove. Usually they can remove by what they like to call shave excision, although I'm not exactly sure because almost none of us shave them off. But we usually will remove them with superficial Westcott scissors. Sometimes they can get inflamed. They can sometimes bleed. They can sometimes grow rather quickly if they're inflamed. So they can be a little confusing to distinguish between some other things, which we'll show some examples of. But by themselves, they really have no malignant potential. So these are just a couple things from the book and from my own practice of different examples. Papillomas, squamous papilloma on the right, you both have the sessile and the pedunculated ones, the sort of a common seborrheic keratitis, the brownish stuck-on piece. This is looking straight at a cutaneous horn. We'll show that a little bit, coming right at you. That's a descriptive term. You have all different kinds of pseudoepitheliomatous hyperplasia, all different types of long, fancy names. You'll get pathology back, but basically you want to know if they're benign or malignant, and almost all of them are benign. So they still like to call these papillomas. Now, how they discovered this, I'm really not sure, but this is a common of verruco vulgaris, which they also classify as a papilloma. And guess what? This one probably is caused by a papillomavirus, either, as your book states, 6 or 11. So it's really hard visually. You can't really always tell the difference between them. And these are some of the more common large group of seborrheic keratosis. Seborrheic keratosis can have keratin and stuff underneath, and you look at this and you see this by itself and you say, oh my gosh, it's pearly, it has a center, it's umbilicated. This person has a huge basal cell. They're going to need to have horrible stuff done. And you do a biopsy of them and it comes back seborrheic keratosis. They can fool you. And I have to admit, when I first started practice, I was fooled by these once or twice. But once you see the keratin material inside it, Basal cells don't have keratin material inside them. Occasionally squamous cells do, but they don't usually look like this. And seborrheic keratosis can also look like almost like a lichen planus type of thing, just a whitish sheath of keratosis on the lid. Now, cutaneous horns are interesting. We'll show some a little bit later, but that's just a descriptive term. It looks like a little unicorn. Does it tell you whether it's benign or malignant? No. If you're going to remove one of these, you better biopsy it, because some of them have a base that's squamous cell carcinoma, even though they can look identical to the most common. Most of these are benign, but sometimes, again, you can be fooled. Make sure you remove it completely and send it to the pathologist. Okay, the second most common are inclusion cysts. They're elevated, white, usually solitary, but you can get more than one. And they're filled with keratin. These will always be referred by primary doctors for removal of a sebaceous cyst. Well, we all know that they're not sebaceous cysts. They're filled with keratin. They're from the infundibulum of the hair follicle, and there's often a central pore. If you look real close to the slit lamp of magnification, you can almost see this pilar duct remnant. Here's two examples of different cases which were pathologically inclusion cysts, and here you can see very easily the central pore in this larger one. A larger type of inclusion cyst happens where the thick hairs of the scalp occur. And remember, the brow is part of the scalp. The brow is not part of the eyelid. And we will get these large cysts, and they'll be referred sometimes as abscesses. Many of them are not abscesses. Many of them are these pilar or tricholemal cysts, which sometimes will break open and get inflamed. So we usually like to try to calm these down before removing them, because no matter how you're going to remove these, you're going to leave some scar that the patient's not going to like. These happen in the area of large hair follicles. 90% of them happen on the scalp, which the brow is part of. And if you really want to x-ray them or scan them, 25% of the larger ones have some calcification in them. Another good board question. So here's a couple of patients that came in, and all of a sudden they said over a week they developed this. Well, what they had a smaller one before, and they broke. And they got some keratin leakage and got inflamed. And always think this. It's not necessarily a pseudotumor. It's not an abscess. You want to try to treat them as conservatively as you can, if you can. Adnexal tumors are not as common as epithelial tumors. Adnexa are the things that start underneath the skin but push up through the skin, like the sweat glands, the hairs, and things like that. Syringomas are multiple little eccrine glands. They're very hard to treat. They leave scarred. You can't remove them. They're down underneath the skin. They're really in the dermis or subdermis area. Sometimes we'll see larger eccrine ductal cysts on the eyelid, which I'll show you an example of. Very similar to that are the apocrine, the glands of Moll cysts, which can be very large, just like this, and we've all seen these laterally. They're also called pseudoriferous cysts. The nomenclature between the ductal cyst and the pseudoriferous cyst is also very hard, because they can look identical, and the pathologist will tell you what they think the difference is. And this is just an example. Here's one that was called an apocrine pseudoriferous cyst, and here's one that was called an eccrine ductal cyst on pathology. And if they walked in the room, I couldn't tell the difference. You could see sometimes they have this bluish tint, and that's because the Tyndall effect of the light going through the skin and sort of reflecting back the grayish-bluish fluid, which is actually usually clear fluid, unless there's some blood in there. Molluscum you're all aware of. Someone comes in with a pink eye, and you see a bump on the lid, even though you're tempted to say maybe that's a basal cell because it has an umbilication. Usually it's a benign molluscum. They're viral, and they cause follicular conjunctivitis when they're on the eyelid margin. You could be tricked by this. I have been tricked. Most ophthalmologists have seen chronic conjunctivitis a few times before they notice that there's a little tiny little lesion somewhere on the lid. So always look for the lesion in a chronic, especially if it's a unilateral follicular conjunctivitis. And here's a pathological enlargement. You can see that what happens is the virus infection will leak this material into the conjunctiva and cause the follicular lesion. Sometimes in children, sometimes in people with decreased immune systems, you can get a whole lot of these molluscums. Xanthelasma, just a couple things. These are a bane to certain oculoplastic people because they happen in this area. They recur a lot. They're underneath the skin, and they're sometimes even not only subdermal, but they're also sometimes into the orbicularis muscle. And they could come back. You could remove them. They cause scarring. As you know, some of these people have high cholesterol, even though they're cholesterol pathologically, but most people have normal lipid profiles. But you always ask the patient if it's been checked. Over the years, excision, trichloroacetic acid, CO2 lasers, they're very difficult to treat when they're recurrent, and they usually happen in younger people, so there's not a lot of extra skin to move around. They always happen medially, almost always happen medially in the upper and lower lids, and no one exactly knows why they're deposited in those areas. And let's go just very briefly, eyelid margin nevi. This is a red one, but oftentimes the amelanolic nevi may look just the same color as the skin. There's no lash loss. It's just displaced. And you have to be very careful when you're removing these, because if you think it's a tumor and you want to remove the whole thing, it goes into the tarsus, into the lid. You're going to deform the lid greatly. They're usually very slow growing, so I tell patients who want to have them removed, here's what we're going to do. We're going to try to remove it just to the area of the lid margin, find out pathologically what it is. If it's benign, you'll come back in a few years and we'll do it again, because we don't want to deform the lid, cause a notch or trichiasis, which definitely can happen with these. And these are just a few different nevi, some pigmented, some flat, some elevated. These are all biopsy-proven nevi of the lid. Let's shift gears to the last part of the formal portion before I show you some examples, and that's skin cancer. Skin cancer of the lid, basal cell, second, basal cell, third, basal cell. Basal cell is 90-95% of all skin cancers of the lid. Yes, here at Wills, you're going to see a lot of unusual things and different referred in different cancers, but in real life, basal cell, basal cell, basal cell. It's the most common. Always have a suspicion. When it's nodular like this and it's raised and it has a pearly and a crater in the center, it's pretty high to be, easy to be suspicious. There's little blood vessels growing into it, has a central ulcer. It's a very high percentage. Half of them happen on the lower eyelid. Next common is the medial canthus, and that's the most dangerous area because of things we'll talk about in a second. Followed by the lateral canthus and the upper lid, all thought to be due to ultraviolet exposure over the years in people who are susceptible. And there's a lot of stuff in your book about that. The medial ones are more likely to infiltrate more deeply. There's the lacrimal system, the sinuses, different areas we have to worry about. So be more suspicious and more aggressive with ones that are medial rather than just watching them if you're not sure. Biopsy them. There's some controversy on if it is a basal cell when you remove it, if you have to remove the tear duct or the punctum. There's controversy in our department, not in our department, but in our field, of whether you should reconstruct the lacrimal system at that time or whether you should wait a few years before you know that there's no tumor, so you're not connecting possible tumor with the lacrimal system, which could then grow into the nose. So nodular are easy to see. I'm going to show you a number of examples of basal cells. Morpheoform is harder to know. Here we have lid lash. We have sort of an excoriated lid margin, but it doesn't look pearly. It doesn't look nodular. Slight elevation, but these are the ones that we're more scared of because we can't tell where they start, when they end, and patients don't come in early for these. They just think they have an irritation. Take your finger and push on the lid and palpate it. If it feels like cardboard, be more suspicious. These are usually spread farther than you think. They have a radial growth pattern, and sometimes some pathologists think it doesn't exist. Some people it does with skip areas. So palpation is important with these skin tumors. Induration behind the visible margin suggests malignancy. This is an old Mohs slide, but I think it's still good. It shows the red is what you see on the skin, and we hope for spherical growth, but sometimes we have morpheoform. We could have eccentric growth underneath the skin. And with squamous cell, especially, and some others, we could have planes of least resistance and also spread along blood vessels or nerves. And this could be a very big problem, especially with squamous cell. Most basal cells are going to remove with frozen section, either doing it yourself or doing it with a Mohs surgeon who does different types of frozen sections and mapping. As an alternative, if a patient can't go through surgery or it's very small, we could offer them cryotherapy, which has like an 80% success rate, but not in the medial canthus. Don't do it there. Or radiation is occasionally used, even by Mohs surgeon, when there's a huge tumor on the face before doing the Mohs procedure. This is an example of a benign appearing lesion, no lash loss, which ended up was an OR nurse where I work, and it actually turned out to be basal cell. This is a much more obvious patient with basal cell. A little cystic basal cell, just a little erythema of the lid margin. All these are basal cells, and these are from my patients and from your book that are just different basal cells. Just look at them. Just always be suspicious for basal cell. Pigmented. Pigment can happen in any lesion. Just because something's pigmented doesn't mean it's benign. Doesn't mean it's a nevus. You'll still have to think basal cell in these also. Something is an elevated cyst. It's an unusual looking cyst, but it's still a cyst. All cysts are not benign. Sometimes you can get cystic basal cell. Okay, let's move on to some of the more rare things before I show you some other examples if we have time. And I won't, and please leave whenever you need to. Sebaceous cell carcinoma often is very long to diagnose correctly. People may have blepharitis. They may have chronic chalazion, which keep on coming back. And it's seen more commonly in the upper lid than the lower lid. And it is highly malignant, has local spread, and also has metastatic spread. This is a patient that had blepharitis for like a year, different ophthalmologist, and was brought in. I flipped the lid and looked at it, did biopsy, and it was sebaceous cell. Brought it down. We kept on removing the lid. By the time I removed all the upper lid and was into the orbital fat, everything was still coming back as positive with sebaceous cell. So sometimes this could still be a horrible surgical outcome for the patient, and you have to discuss it with them ahead of time. There are newer techniques now. This was many years ago where maybe this could be avoided. In some cases, as you know, the Shields do a lot of cases with Jackie and Mary and Bob and Yuri with some of these big reconstructions. But sebaceous cell carcinoma has this unusual appearance under oil red O. So you always want to let the pathologist know that you're thinking of sebaceous cell. And this patient, unfortunately, had to have an exoneration because of that. Actinic keratosis, scaliness, redness is the most common precancer in the eyelid. It's caused by sun damage. There are different ways to treat it. We usually want to at least biopsy to remove it. Only about 12% of them eventually go on to be frank carcinomas. And luckily, the squamous cell carcinomas that arise from actinic are not as aggressive as those that rise de novo. And 25% of them clinically will disappear within a year, and you can have waxing and waning of these lesions. Keratoacanthoma, when I was training, was called not a cancer. Now almost all pathologists call it a squamous cell carcinoma. And we're talking about the lesions that grow rapidly over a week or two and get very big, have a central ulcer, get extremely inflamed. And the interesting part of this is that removing them in the office and then the healing process often cures them, even though they're considered a form of squamous cell cancer, and they don't always need to go to OR with frozen section, different things. We've shared a number of cases in our department over the years of these that are just amazing how well they do, even though pathologically. And it's thought that it's such an intense reaction by the body that it actually stops it from becoming a more widespread. And these are two very large cases of very fast-growing keratoacanthoma. I labeled this incorrectly. Obviously, these are large keratoacanthomas. Squamous cells are less common. We're not going to talk too much, except I just want to show you an example of a man I treated. He came in and he says, I was down in Florida and they biopsied this cyst of my lid and it never healed and they told me I have to see someone. And I looked up here, so what did you have done up here? Well, I had some skin cancer removed. It was squamous cell. What had happened is this squamous cell had grown along the fifth nerve, first division, and grown into the perineural spread, into the anterior orbit here. And this was biopsied. It was squamous cell. It would have been a horrible reconstruction, but he was elderly. He was healthy. Otherwise, we decided to go the radiation therapy route. And he lived another 5 years into his 90s without having a recurrence of the squamous cell. So squamous cell tends to go along nerves and vessels. Melanomas are much less common. You'll hear more about those from the Shields. When I was training, we first started seeing patients with Kaposi's or Kaposi's, however it's said correctly, and we didn't know what it was. We'd biopsy them. They'd come back as hemangiomas because they're endothelial. No one really knew what they were until HIV started becoming a much more common thing. When I was training, it was not even given a diagnosis of HIV. These are treated in different ways, excision, cryo. Sometimes we send them back to their primary or their oncologist to be treated with oral agents or chemo. They can look like hemangiomas. They can present with redness, look like pyogenic granulomas on the conj. They can look like hemangiomas of the lid. So always just think of this, and especially in the immunosuppressed. And the last tumor I'm going to show is Merkel cell. I've only seen a few of these, but they are horrible. It's a painless nodule. It can look like this, reddish, like Kaposi's. have telangiectasia. They usually grow pretty fast. Luckily, they're pretty rare, and they arise from neuroendocrine origin. 10% of them happen in the periocular region, but luckily I said they're not common. They are very aggressive. A third of them recur. They have a very high metastatic rate as well as local lymph node, and the overall survival rate is only like around 50%. So people I've seen them with were debilitated. Both of them were elderly, and they actually died very soon afterwards from other conditions. But this is a very aggressive tumor, and that's one of the few that we will recommend sentinel node biopsy for, with ENT, of course. We don't do them ourselves, working with us. Thinking that the first regional lymph nodes are the ones that are affected by direct spread. So they go in either with dye or with a radioactive tracer, and we'll go to the lymph nodes that are draining that area. And we only do this for extensive high-risk tumors, sebaceous cell, melanoma, Merkel cell, things like that. Okay, and this is just a melanoma that was done with the lymph node, and you can see the tumor. Okay, for those that want to stay, I'm going to go over about 5-10 minutes of sort of interesting lesions that were misdiagnosed and things. For those that have to leave, please do. This was a patient of mine that was referred by an optometrist after treating it for 2-3 months as a Chalazion. Warm compresses and drops didn't help, and it did look like a sort of a large Chalazion until you looked a little more closely. Pulling the lid down, there was this salmon elevated area, and what did the biopsy show? A B-cell lymphoma. So this is sort of a masquerade Chalazion that became a B-cell lymphoma. Believe it or not, the same year, this other patient was referred by a different person, and their complaint was that I've had lower eyelid edema up and down for a year, and I don't understand. It just goes up and down. I'm looking at them. I wasn't sure there was any edema, and pulled the lower lids down, had them look up, and everything looked a little pinkish underneath the fornix. So I biopsy. You know, when you see the salmon-colored pinkish areas, you biopsy them. And what did that patient have? He also had a very mild form, like a multoma form of B-cell lymphoma. This was a patient about 2 years ago I saw that was referred by a dermatologist that said this patient had a nevus for 6 months, and all of a sudden it changed in its appearance. And it was initially just a flat brown lesion. And here you can see the elevated nodular lesion. So I removed it and biopsied it. And what did it show? It was a malignant melanoma, which are, as you know, are very rare on the eyelid. So this patient ended up having reconstruction and being sent to a melanoma center for workup and follow-up. So that was a masquerade nevus. This was a person who I swore thought I had melanoma, which didn't. This is 32-year-old. The man comes in with a weak history of having this lesion of his upper lid, and he has no history of trauma, which I thought it was probably an infection or trauma when I first saw him. Then I looked closely, and this is what it looked like. The tissue was excoriated, it was breaking down, and I did biopsies of it, and they showed large atypical cells surrounded by inflammation. In fact, the local pathologist said this resembles lymphoma, and I think it could be a lymphoma or a sarcoma. You better start getting him involved with an oncologist. Well, he sent it off, of course, for a second opinion. And when the second opinion came back, by that time, in 2 weeks, the patient's lesion was gone. It was completely gone. I was amazed. And what the final pathology, and some of you may have heard this, some of the visiting professors have shown cases of this over the last 3 years. It was lymphomatoid papulosis, which is a self-healing eruption. And it probably is in the continuum of T-cell cutaneous T-cell lymphomas, but it's not considered a malignant form. It's at the more benign end of it. It's CD30 positive. It does not have metastatic potential, but 10 or 20% of these people have lymphomas elsewhere that need to be worked up. So it's an interesting thing. And let's finish up with talks. When I was training, we always were taught, if a cyst had clear fluid, it's nothing to worry about. If there's a little bit of pigment in it, it may or may not be something to worry about if it's changing color. If it's bleeding or scabbing, you always have to worry about it. If it's umbilicate, you always have to worry about it. You know where I'm going with this. I showed some examples already. If it's duration of growth, it may be something. If it's fast or slow. If it's explosive, it may be something different than if it's slow. And if it palpates differently, you have to be worried about it. So let's just show a few examples that break the rules. Pigment change we talked about. Most things that are pigmented are actually benign. Benign seborrheic keratosis. I think we showed this slide before. What was it? I think it was a benign basal cell. So you have to be suspicious, although most of these are going to be benign. Pigmented seborrheic keratosis, another pigmented basal cell. Just remember, any lesion could be pigmented, benign or malignant. This has a bluish tint. It's underneath the skin, but it was a cyst. It was a pseudoriferous cyst on biopsy. This has a bluish tint, but it does have some blood vessels and some other suspicious characteristics. This was a basal cell. Cysts with clear fluid are usually benign. As you can see, these different eccrine and apocrine cysts, though, are benign. But again, cystic basal cell can be full. There's no really lash loss. There's cystic lesion. This is the case I showed before. They say less than 10% of basal cells of the face are cystic, but they can fool you. Bleeding and scabbing. Oh, yeah, that must be cancerous. If it's bleeding or scabbing, it must. No, it doesn't have to be. It could be inflammation. And these could have friable blood vessels also. Actinic keratosis can bleed, premalignant. Basal cell can bleed. That's what you ask them. You rub it, does it bleed? But I've seen bleeding from molluscum. I've seen bleeding from papillomas where people were rubbing and you can see the blood there. Bleeding doesn't always mean malignancy. Lash loss, classic sign of skin cancer, lash loss. You have lash loss, you got to biopsy it. Well, that's probably true, and usually it is one of these forms of cancer. But lash loss also happens with any kind of chronic inflammation or growth. So here's lash loss, and both of these are basal cell, morpheaform and somewhat nodular. But here's some lash loss. There's no lashes where this inclusion cyst is at. There's no lashes in this person who has this chalazion that keeps on coming back, and that's biopsy-proven benign. So you can lose lashes from anything. Luckily, with the inflammatory ones, they often will grow back after a number of months. Umbilication, we talked about this. Basal cell and keratoacanthoma, the bad players with umbilication. But molluscum can be umbilicated, as can some keratosis, which we showed examples. These are all basal cells. You all recognize those. Keratoacanthomas, you'd all know something was wrong there. But molluscum can also show and be waxy and have umbilication, as can some keratosis. That's why I mentioned that before. Duration of growth. Usually slow growing could be benign or malignant. It's not a helpful thing. So if something's slow growing, it doesn't really help you. Explosive growing can be due to a few things. Benign lesions like a ruptured cyst or inflamed keratosis can grow rather rapidly, as can certain types of malignant lesions such as keratoacanthoma, Merkel cell, and Kaposi. So fast growing doesn't mean always benign or malignant. Ruptured inclusion cyst, ruptured pilar cyst can grow rapidly. Kaposi's and Merkel cell can grow rapidly. And we're going to finish up. Dr. Kirsten was here maybe 3 years ago as the visiting professor. He did 864 lesions he published, had different oculoplastic surgeons. Only oculoplastic surgeons saw these people and made the diagnosis. And when they saw a lesion, they said it's either benign, it's premalignant, or malignant. So of those, and they all went to pathology, and there were only oculoplastic surgeons who do a lot of these. Well, pathologically, almost 2% of those that appeared benign ended up being some type of malignancy. On the other hand, of those that were thought to be definitely malignant, not premalignant, almost 8.5% to 9% were actually benign. So bottom line is you can't tell by looking. Malignancies were diagnosed as papillomas, even inclusion cysts, nevi, hydrocystoma. You'd think, well, gee, those are obvious looking. How could you miss up? You can. So if you're going to remove something, if it looks anywhere and you're not sure, even if it looks very benign, try to biopsy it unless there's a reason not to. Malignancies in benign appearing lesions were basal cells, lymphomas, squamous cells, and adenocystic skin carcinomas. Here's a couple of lesions which you could look at and say, I'm not sure what's going on here. They were both malignant. One was a keratoacanthoma, which grew rapidly. One was a metastatic breast. So, and cutaneous horns we talked about. Well, these two patients were actually biopsied and removal. What happened? One was benign, and this one was squamous cell carcinoma. So you can't tell with the cutaneous horn just by looking at that it's benign. So the take-home point is that even with people who deal with it all the time, clinical diagnosis alone is not sufficient to differentiate between benign and malignant. And I thank you for your patience, and have a nice day.